Today we'll be talking about a medial elbow pain in a baseball pitcher. This is going to be more complicated, a lot more complicated than previous cases have been, and will involve both the upper and the lower quadrants. So the etiology search will be more extensive and maybe a little bit more difficult to interpret. Let's see how we do. I don't think I've ever actually written down these general principles, just sort of understood them. So, as I say, this is going to be a complicated case, and it's going to be fairly long as well. So let's get this done. So the general principles of looking for etiology. In order to work sensibly, that is rationally, the internal stresses, that is neurological, neurophysiological and mechanical stresses, they've got to work with the external stresses, and they must both be rational and reasonable. For example, if you're looking at somebody with a headache and you find a laterally rotated cuboid in the foot, then you need to be able to link this up, not just rationally and trace it through, but also reasonably. Is it reasonable that a subluxed cuboid could give this person headaches of the type they're describing? So rational and sensible. To make sense again, the internal stresses have to be able to produce the immediately proximate diagnosis. That is, the cause of the primary diagnosis must be able to directly cause that. The cause of the primary diagnosis must be able to produce that, and so on. If you can link all these up, it doesn't matter if the last etiology can produce the first one or not, just that that chain is unbroken. If it breaks anywhere, then your whole etiology hypothesis falls to pieces. You've also got to have external stresses that make sense, so that these can take advantage of the more vulnerable internal stresses, and so the two can cooperate in causing the diagnosis, that is, damaging the pathological tissues. And also the internal mechanical stresses are going to be more potent the closer they are to the pathological tissues than the further away they are. So we go back to the cuboid again. If you find the cuboid and they've got a headache and there's nothing in between them, this doesn't make any sense at all. There's nothing reasonable about this. So always look for more proximate stresses than distal stresses first, always. So here's your case, 28-year-old baseball player, single A level, that doesn't really matter, complaining of pain at the right medial elbow for a couple of weeks. The pain is getting worse. The more he does, the worse it gets. There was no incident, no mechanism of injury, and the onset was gradual over that 2 weeks. Now it could play, and it hurt him a bit when he was playing, but now if he pitches more than 3 games, then he will have significant pain and prolonged aching for the rest of that day and sometimes into the evening. There's no history of elbow pain, but it does occasionally get right shoulder point pain after a game. And there's no medical history that could explain this patient's pain. Okay, so let's have a look at the selection of H1, the first hypothesis, and we'll use negative differential diagnosing. That is, we'll run up a number of differential diagnoses and disprove it by a negative high sensitivity test. So, first one that comes to mind for me anyway is common flexor tendinopathy, and we can disprove that simply by palpating for 10 minutes and not finding it. Similarly with an MCL degenerate tear, again palpation would be negative. Biomechanical dysfunction at the ulnar-humeral joint, negative quadrants. Ulnar-humeral joint arthritis, negative quadrants, and an ulnar neuropathy, negative for symptoms or signs of a neurological nature. Now, you can run into problems with this because let's say that we find that we have 2 positive palpate, everything's positive, let's say everything's positive, then you're going to have to shift what you're doing from a negative differential and move towards a positive differential here, or just pick one at random, one of the hypotheses at random, and go through your EIS, your script focus hypothetic inference. But if you can get away with disproving the differential diagnosis much faster and easier and probably more certain. Okay, so this is our hypothesis selection weights. The right medial collateral ligament was tender, as was possibly the CFT, the common flexor tendon. Quadrants are negative and there were no neurological signs or symptoms. Now, what we got is a possibility, given those two things, that we have a tendonitis, because it sounds more inflamed than not, with the aching going on afterwards. And it's a common flexor tendonitis, and also an MCL tear. So one of those two things based on palpation. But now we have to look for proving one of them, and so on, and by doing that, disproving the other. So what we find is the isometric flexion tests are negative, as is the isometric stretch test. So basically, we haven't got a common flexor tendon, and the tenderness was irrelevant. It was part of the tenderness of the MCL tendon. It may have been due to segmental facilitation. So now we stress test the posterior band of the MCL, actually all of the MCL, obviously anterior and posterior band, and we find that the stress test is positive. For the posterior band, it shows instability and pain. Okay, so we'll attack now the hypothesis of MCL tear with bias and error correction and also differential diagnosis. Now, basically, we've already done differential diagnosis. All of the things we would have brought in at this point, we've already tested and found them not to be present. So we can say now, apart from premature closure, and you have to decide whether or not you think that's a possibility, whether you do it or not. H2 now becomes a diagnosis. That is a right MCL degenerate tear with a valgus instability. Okay, let's look at what we need to know about the pathology. So we made a diagnosis as attenuation of the medial collateral ligament, the posterior band of it, and this controls valgus inflection, whereas the anterior band does it in extension. So the stress has to occur when the elbow is flexed, and this is presumably at the wind-up. This requires full lateral rotation of the shoulder, and it's done in about 90 degrees of abduction. So the position of forces involved in the wind must be thought about when you're looking at the mechanical stresses action on the elbow. So let's look first at the potential neurophysiological problems, and that'll give us some idea of how well the joint is being stabilized dynamically, and then that will lead us to some conclusions about the inert stabilization of the joint as well. So this is what you've got to do, and it's done much more quickly than this and a lot less formally. You have to consider the pathology you found and how that can be brought about by most about proximate tissues, because as you get more and more hypotheses coming up, then they get less directly involved in the primary diagnosis. So we're clearly interested in the dynamic stabilizers of the medial elbow. Now this is common flexor tendon muscles. These ones are almost perfectly aligned to stabilize valgus, at least dynamically. So we look for weakness there. If we find weakness in these muscles, which is going to be well, it'll be easy in this case because it isn't tendinopathy, but if we do find weakness in these muscles, then we start considering whether the quality of the weakness, the distribution of the weakness is telling us whether they have a radiculopathy, and if that radiculopathy is a hard radiculopathy or a soft one in the form of XT compromise, or whether we have a median neuropathy or segmental facilitation. We can't be too concerned about breaking weakness with this type of test, and we'll do that in a bit. So now, if this turns out to be no, we then can test eccentric weakness, which is what we can do anyway. We test eccentric weakness of the flexor muscles, and if that's the case, then we look at the biomechanics of the wrist and the elbow. If they're positive, then we have reflex inhibition. Now, the reflex inhibition actually becomes a lot more significant if the biomechanical dysfunction is in the wrist. We know they've got a biomechanical dysfunction, they've got an instability in the elbow, we've got a valgus instability, so we know there should be reflex inhibition from that. So we're going to be puzzled if there's not. But if there is, the significant one is going to be in the wrist, because the wrist then becomes a target for treatment. If there's no eccentric weakness of the flexor muscles, then we move on to mechanical causes and etiology for that. Now, as I said, the etiology search can span both quadrants, upper and lower quadrants. So you could actually consider this as a global problem if you find those etiologies rather than a regional or a local one. But as the principle suggests, we'll look local first and we'll worry about the more distant ones later on. So we're looking for mechanical causes of this degenerate tear, and we'll look at the elbow first, and we'll check quadrants of the elbow. Now, we've already done that if we did it when we selected out the hypotheses, but if not, we're going to do it again now, and we'll look at range of motion of the elbow via the quadrants. Also, pronation and supination. Now, if you think about it, you've got to be able to fully supinate your arm as you unwind up, and if you can't do that, then there's going to be added stress to this. Similarly, if we've got an abducted arm, then you're going to have trouble getting full flexion with this as well. So that's also going to stress the elbow. So we're going to look in the elbow for mechanical stresses. In the right shoulder, we'll look at decreased elevation, lateral rotation. Is there anything stopping that from happening? Is the glenohumeral joint blocked by labral inclusion? Is there anterior capsular scarring and so on? At the AC joint, we're going to look for basically an anterior subluxation that won't allow the clavicle to come back on the acromion. Those are all causative issues. In the thoracic spine, we need to be able to completely rotate to the left. We also need to be able to get the arm up. So if the thoracic vertebra can't extend because they're subluxed in flexion, or you have a left rotating subluxation, which is to say a transverse subluxation one way or the other, but it's blocking right rotation, or the first and second ribs can't come down, then that's going to limit that, and then that's going to add more stress to the shoulder, and it may either, and it may well be the cause of the labral problem, including the shoulder. So these will have to be dealt with. And globally, the big rotator in the trunk is T1112. Is that subluxed into left rotation? Is the right SI joint able to extend? Is the left able to flex? And you can see that in the pictures there with the right-handed picture. The left ankle, you have to be able to come over the top of that, even during the wind-up. And it has to be able to pronate. So we're looking for those subluxations to limit that, and similarly the subtalar inversion may also limit your carry over the leg. Now, as I say, these things in the foot are going to be a lot less important as etiologies than around the shoulder itself, but this is what we're going to be looking at. All right, so let's have a look at the mechanical aspects of this now, and what we found. So when we checked the elbow with its quadrants and its pronation and supination, we had full range of motion and it was pain-free. Now, in real life, the extension, the flexion and supination quadrant may actually be painful, because that's going to be pulling on that posterior medial collateral band of the ligament. So you can expect that, and that should only be on the medial side. If it's being seen in the joint, then it's a problem. But we've already done this, but if we haven't, we're going to do it again. And as I say, that's what we found. The elbow is fine. So there's no mechanical stress coming from the elbow itself. The right shoulder, what we find there is an anterior subluxation of the labrum. This is causative, it's stopping the arm from coming back, so you're going to have to get that movement somewhere else. The AC joint is subluxed anteriorly, that's what we found, and this is the somewhere else that it's getting it from. It's stressing out the elbow, and it's also stressed out the AC joint and jammed the clavicle anteriorly to try and get more movement. In the thoracic spine, we find the first rib is subluxed superiorly, they always are when they are subluxed, and the right T3-4 is left rotated, so it's a transverse subluxation one way or the other. It doesn't really matter which way it's subluxed, it's how it blocks its movement. So it's a left rotation subluxation for our purposes right now. T1112 is subluxed into left rotation. So it could be an extension, an extension subluxation on the left, or it could be a flexion subluxation on the right. That's all going to stop you from coming back around that side to the right. The left ankle is unable to dorsiflex, so it's a causative issue, and the inferior tib fib joint has an instability there from whatever cause, and that's also causing is a causative issue because it's allowed the subluxation of the ankle. So, having gone through all of that, this is what you end up with. These are the primary and secondary diagnosis, or the diagnosis and the hypotheses diagnosis, if you prefer that. But this is what we found. If you look back on what we did, you found that we started from the diagnosis, from the elbow. We didn't jump straight into the hypothesis, we made the diagnosis. And then we looked step by step backwards from the primary diagnosis to what immediately caused that, to what immediately caused that, and so on. And all of these are viable for treatment, but if you don't want to treat all of them, treat the local ones and leave the other ones till later. Almost certainly the patient's been fine with most of this, and something that's just tipped him over the edge. So you can get rid of the big stuff, which would be, for me, the labral subluxation, anteriorly stopping elevation of the shoulder. That to me would be the biggest one. I would do that, see how this works out, and then decide where you're going to go from there as he does more activity. So if this comes back fairly quickly, then you're going to have to get into this a lot more. Almost certainly you're going to have to do the rib and the thorax, but because they're causing the labral problem. The rest of this stuff, though, are contributors and may not have a big issue with it. You may also find that there's been a change in training, change in footwear, something else has changed that's kicked this whole cascade off, and you might want to look at that as well. So, reasonably complex. It's a global issue rather than simply upper quadrant or a local issue, and it's very satisfying when you find this. All right, guys.